be a speaker in this important conference, the Karachi International Conference, and I'm going to talk about type 2 diabetes in the young. According to the Center of Disease Control, 1 in 3 children born in the US in 2000 will become diabetic in the future, and mostly type 2 diabetes. Is it an epidemic or not? Incidence of type 2 in the youth is increasing and probably underestimated, and the population-based estimate indicate that there is 10-fold increase in the incidence of type 2 diabetes in the youth and young adults over the past 10 to 15 years. Type 2 diabetes in the youth before 1990, only 5% of children or adolescents were diagnosed with diabetes type 2 diabetes. Now they account for 30 to 50% of new cases of diabetes in the youth, and the increasing incidence of type 2 diabetes in the youth parallels the national data estimating a triple in the rate of overweight in adolescents in the past 20 years. And it is considered the first consequence of the epidemic of obesity. There is a changing face of type 2 diabetes in the youth in US, and according to this study done between 1987 and 1996, there is increasing incidence of type 2 diabetes in different US states. These are the risk factors for type 2 diabetes in the youth and young adults. There is non-modifiable risk factors for youth onset type 2 diabetes in the form of genetics or epigenetics, a strong family history of type 2 diabetes in the first or second degree relative, or being an offspring of a pregnancy complicated by gestational diabetes and possibly an obese mother, minority race, insulin resistance of puberty, and genetic susceptibility detected in the first decade of life, manifested as impaired insulin sensitivity, reduced insulin secretion in an otherwise healthy young with a family history of type 2 diabetes. This genetic susceptibility, when combined with environmental factors, lead to obesity and sedentary lifestyle, may ultimately translate to type 2 diabetes. In a study of youth with obesity, a genetic risk score of beta cell dysfunction from 5 single nucleotide polymorphism was associated with higher chance of prediabetes and type 2 diabetes in the youth. There's dozens of specific genetic variants linked to type 2 diabetes. In the youth onset type 2 diabetes, there is major modifiable risk factors in the form of obesity, excess nutritional intake, low physical activity, increased sedentary behavior and lifestyle, decreased energy expenditure, and other potentially modifiable risk factors include chronic stresses and or depression, mood, and sleep-related disorders. Currently, 25 of obese children are pre-diabetic, and if we do nothing, 35% of children born in 2003 will develop diabetes in the future, and those with diabetes will lose an average of 13 years of their life. This is a study showing overweight and obesity among school children between 5 and 17 years old in different places of the world, and this is the prevalence of overweight and the prevalence of obesity and maximum in the Americans. This is another study showing the enrollment in daily physical education classes between 1991, showing reduction in the exercise hours in 1995. Children are becoming more sedentary with less physical exercise in the school, more screen time, and only 50% get regular physical activity, and 14% of the teenage children or adolescents report no physical activity at all. We come now to an important question: what distinguishes type 1 from type 2 diabetes in the youth? And pediatric diabetes is a difficult diagnostic specialty. This is the childhood obesity. Some overlap with type 1 diabetes in the young. They are mostly average weight or underweight, but some of these type 1 diabetics may be obese. But type 2 diabetes in childhood and adolescents, they are mostly obese. Monogenic diabetes, diabetes with some genetic syndromes. And this table shows the differences between type 1 and type 2 diabetes. In type 1 diabetes, 20% of them may be obese, and in type 2 diabetes, more than 85% are overweight. And the course in type 1 is rapid, but in type 2, it's indolent, with no symptoms mostly. The diabetic ketoacidosis occurs in 35 to 40% of type 1 diabetics, while there is mild ketonuria and DKA in 5 to 25% of type 2 diabetics in the young. A relative with diabetes, we can find 5% with type 1 diabetes in those with type 1 diabetes in childhood or adolescence, and up to 20% may have history of type 2 diabetes, while in type 2 diabetics, 74 to 100% are having a relative with type 2 diabetes. Comorbidity in type 1 diabetes, thyroid disease, adrenal disease, vitiligo or celiac disease. And in type 2 diabetes, there is increase in the polycystic ovary syndrome in girls and acanthosis nigricans in both girls and boys. The C-peptide can be preserved at the diagnosis of type 1 diabetes, but it's normal or increased in type 2 diabetes, and the presence of antibodies in type 1 diabetes happens in up to 85%, but they can also be present in 15% of type 2 diabetics in the young. Another question. The presentation, is it asymptomatic or symptomatic? And the study showed that the mean age for type 2 diabetes in the young is 12 to 14 years, and girls to boys ratio is 1.7 to 1. It's more prevalent in girls, and obesity and body mass index happens in more than 95th percentile, and the minority groups 94%, strong family history in 74 to 100%, acanthosis nigricans in 56 to 92%. And diagnosis can be made with symptoms, not screening, because hemoglobin A1C was between 10 to 13%. Weight loss happened in a certain percentage of the patients. with ketosis in 16 to 79% in different meta-analysis, and DKA in 5 to 10% of the cases. This is a picture of the acanthosis nigricans. And according to the American Diabetes Association, 2021 went to screen for type 2 diabetes or pre-diabetes in asymptomatic children and adolescents in the clinical setting, in overweight more than 85th percentile or obese more than 95th percentile, who have one or more additional risk factor in the form of maternal history of diabetes or gestational diabetes, family history of type 2 diabetes in the first or second degree relative, race or ethnicity, signs of insulin resistance conditions in the form of acanthosis nigricans, hypertension, dyslipidemia, polycystic ovary syndrome, or small for gestational age birth weight. Another important question, what are the treatment targets in use with type 2 diabetes? Are they the same as in adults or not? And according to ADA 2021, the pharmacological therapy and behavior counseling should be initiated for healthy nutrition and physical activity at the diagnosis of type 2 diabetes. In incidentally diagnosed or metabolically stable children with hemoglobin A1C less than 8.5 and they are asymptomatic, metformin is the initial pharmacological treatment of choice if renal function is normal. In use with marked hyperglycemia with blood glucose more than 250 milligram or hemoglobin A1C more than 8.5% without acidosis at the diagnosis, and they are symptomatic with polyuria, polydipsia, nocturna, or weight loss, they should be treated initially with basal insulin together with metformin. In patients with ketosis or ketoacidosis, the treatment should be with subcutaneous or intravenous insulin initiated to rapidly correct the hyperglycemia and the metabolic acidosis. And once acidosis is resolved, metformin should be initiated while subcutaneous insulin therapy is continued. In individuals presenting with severe hyperglycemia with blood glucose more than 600 milligram per deciliter, consider assessment of hyperglycemic hyperesmolar non-ketotic coma. If the glycemic targets are not met with metformin with or without basal insulin, liraglutide is approved therapy and should be considered in children 10 years of age or older with no past medical history or family history of medullary thyroid carcinoma or multiple endocrine neoplasm type 2. And this is the figure for management of new onset diabetes in the youth with overweight or obesity according to the hemoglobin A1C and the presence of symptoms and the presence of diabetic ketoacidosis or hyperosmolar non-ketotic diabetic coma. And we should check the pancreatic antibodies if positive or negative, and if positive, continue or initiate multiple daily injection of insulin or pump therapy as for type 1 diabetes and discontinue metformin. But if negative, continue or start metformin, and if on insulin, titrate guided by SMBG, and if goals are not met, continue metformin, consider adding liraglutide and titrate insulin if using basal insulin only or to give branchial insulin. Metformin improves the glycemia in type 2 diabetes in the adolescents, and this study was a double-blind study and showed the importance of adding metformin to type 2 diabetes in the adolescents. Metformin is well tolerated, but some may complain of abdominal pains in 25% of cases and diarrhea in 17% of cases, but no treatment withdrawal for the drug-related gastrointestinal side effects was found. Another question: what are the associated risk factors in use with type 2 diabetes? There is specific lipid and blood pressure abnormality in children with type 2 diabetes. The lipids, same as adults, increased triglycerides, slight elevation of LDL and decreased HDL, and the blood pressure 3.4% systolic blood pressure increase more than 95th percentile, and 20% diastolic increased more than the 97th percentile. The question now: how can we stop this diabetes epidemic in the youth and children and young adults? Lifestyle management, according to the ADA, is very crucial. At least 60 minutes of moderate to vigorous physical activity daily with muscle and bone strength training at least 3 days per week, and healthy eating patterns. And according to the International Diabetes Federation recommendation for healthy diet for general population, and to choose water, coffee, or tea instead of fruit juice or soda drinks or other sugar-sweetened beverages, to eat at least 3 servings of vegetables every day, including green leafy vegetables, and eating up to 3 servings of fresh fruits every day, choosing nuts, pieces of fresh fruit, or yogurt for snack, to limit alcohol intake to maximum, and to choose lean cuts of white meat, poultry, or seafood instead of red meat or processed meat, to choose peanut butter instead of chocolate, and to choose the whole grain bread, brown rice, or whole grain pasta instead of white bread, rice, or pasta, and to choose unsaturated fat like olive oil, canola oil, corn oil, or sunflower oil instead of saturated fats like butter, animal fat, coconut oil, or palm oil. This is again the WHO recommendation for physical activity in different age groups, and for children and youth age 5 to 17 years should do at least 60 minutes of moderate to vigorous intensity physical activity daily. Type 2 diabetes in the youth and children is a team approach between endocrinologists, physicians, general practitioners, diabetes educators, dietitians, student himself and family, and school and media. How do you initiate a change? School can provide quality daily physical activity classes, nutrition awareness campaign, parent education awareness campaign, psychological education and psychological intervention, school nutritional policy, and the main message: patients are important influence on their children's eating and activity habits. And again, the main message: change takes time, begin by taking a few small steps. Thank you.